Hello and welcome to our new topic, one of the most important ones. Today's topic is about a group of very frequently prescribed drugs that are used to treat a highly prevalent cardiovascular disorder globally, responsible for so many complications and constitutes one of the largest contributor to the non-communicable disease burden. Yes, that is hypertension or high blood pressure. Since many antihypertensive drugs are also used in other disorders or have already been discussed separately, like diuretics or adrenergic antagonists, we will focus here on those drugs which are not discussed anywhere else, to avoid duplication of the content. So, let's start. By the end of this session, you should be able to describe the main drug targets in systemic hypertension, classify antihypertensive drugs based on their mechanism and site of action, and explain their pharmacokinetics, mechanisms, adverse effects, and clinical uses. You'll also learn how we combine these agents rationally for effective blood pressure control. Let's begin with the definition of normal systemic blood pressure as per JNC 8 guidelines. A normal reading is below 120 over 80 mm Hg. For most adults, our target control is below 150 over 90 mm Hg. Blood pressure is a function of two factors, cardiac output and peripheral resistance. Various factors control or influence one or both of these factors, and we use drugs to adjust one or both of them in short term as well as long term to keep blood pressure in optimum range. Recall the basic classifications: primary or essential hypertension versus secondary hypertension, and systemic versus pulmonary hypertension. We also distinguish systolic from diastolic forms, which have slightly different pathophysiological implications. To lower blood pressure, we have several pharmacological strategies. First-line agents include renin-angiotensin system blockers such as ACE inhibitors and angiotensin receptor blockers. Calcium channel blockers are equally common, particularly in elderly and Afro-Caribbean patients. Sympatholytic drugs, including beta and alpha blockers, act as useful adjuncts. Then we have vasodilators, especially important in emergency situations, and diuretics, which we'll cover in a separate lecture. Here we can see the central role of the renin-angiotensin-aldosterone system in regulating blood pressure and fluid balance. This system is responsible for many long-term complications seen secondary to systemic hypertension. No wonder this system becomes our main focus for effective antihypertensive therapy. As you can see, the liver produces angiotensinogen, which is converted by renin to angiotensin 1. Then by angiotensin-converting enzyme or ACE into angiotensin 2, the main vasoconstrictor. Angiotensin 2 also stimulates aldosterone release from the adrenal cortex, leading to sodium and water retention. This cascade is a crucial target for therapy, because we can intervene at multiple points to reduce vasoconstriction and fluid overload. This illustration depicts how renin-angiotensin-aldosterone system works and where we can interfere. ACE inhibitors such as captopril, enalapril, and lisinopril block angiotensin-converting enzyme. Instead of ACE, we can directly block the receptors of angiotensin 2 with drugs like losartan and valsartan. Apart from that, it is possible to block the aldosterone receptors to reduce retention of sodium and water, or block the renin itself. Take a close look at this diagram. It was the pit viper which brought our attention to the role of angiotensin-converting enzyme in this story due to presence of a natural inhibitor in its venom. The ACE inhibitors such as captopril, enalapril, and lisinopril act on angiotensin-converting enzyme. Remember, ACE also degrades bradykinin, a vasodilator. So when we inhibit ACE, we not only lower angiotensin 2 but also increase bradykinin levels, which further promotes vasodilation. That's why some patients develop a persistent dry cough, a hallmark of bradykinin accumulation. ACE inhibitors can be classified as active drugs, like captopril and lisinopril, or as prodrugs that need hepatic activation, such as enalapril, perindopril, and ramipril. Some drugs have both an active form and a more potent active metabolite, for example trindolipril, which becomes trindoliprilat. This metabolic activation often influences their duration of action and dosing frequency. These agents reduce both preload and afterload by relaxing arterioles and veins. By decreasing angiotensin II and increasing bradykinin, they reduce vasoconstriction, help prevent cardiac remodeling, and improve renal perfusion through dilation of afferent arterioles. Clinically, this translates to benefit in heart failure, diabetic nephropathy, and postmyocardial infarction management. That is why we use drugs targeting renin-angiotensin system to treat many cardiovascular disorders. The main adverse effects include dry cough and, rarely, angioedema, both linked to bradykinin. We must also monitor for hyperkalemia due to decreased aldosterone and avoid their use in pregnancy because of fetal toxicity. Renal impairment may occur, particularly in patients with bilateral renal artery stenosis. Close monitoring is crucial. Next are the angiotensin II receptor blockers, ARBs. Early peptide agents like ceralasin are now obsolete, replaced by non-peptides such as losartan, valsartan, irbesartan, candesartan, and eprosartan. Because being peptide, it had to be given intravenously and could cause severe hypersensitivity. As the name suggests, ARBs specifically block AT1 receptors of angiotensin II, reducing vasoconstriction and aldosterone secretion, while leaving unopposed the stimulation of a second type of its receptor, called AT2, enhancing nitric oxide release and vasodilation. ARBs have efficacy similar to ACE inhibitors but largely without the bradykinin-mediated side effects like cough or angioedema. That makes them an excellent alternative for patients intolerant to ACE inhibitors, such as asthmatics. However, they share the same contraindications in pregnancy and in severe renal artery stenosis. Another target is renin itself. Drugs like propranolol lower renin secretion indirectly through non-selective beta blockade because it depends on beta-2 receptors. Direct renin inhibitors such as aliskiren act by blocking the catalytic site of renin. Their blood pressure lowering efficacy is similar to that of ARBs, but again, they are contraindicated during pregnancy. Brain natriuretic peptide, or BNP, is released from the heart in response to stretch and volume overload. It promotes vasodilation, natriuresis, and reduces renin secretion. Nasiritide, a synthetic BNP analog, is used in acute decompensated heart failure, although adverse effects like hypotension and acute renal failure limit routine use. Hypertensives having heart failure are good candidates for this drug. Aldosterone is a mineralocorticoid that increases sodium and water retention. Spironolactone acts by competitively blocking intracellular aldosterone receptors in distal renal tubular cells, thereby promoting sodium excretion and potassium retention. Besides hypertension, it's useful as a potassium-sparing diuretic and in managing heart failure and hyperaldosteronism. Now let's move to calcium channel blockers. They block L-type calcium channels, decreasing intracellular calcium and thus reducing vascular smooth muscle contraction and cardiac workload. Dihydropyridines, such as nifedipine, amlodipine, and isradipine, are more selective for vascular smooth muscle. Non-dihydropyridines like verapamil and diltiazem act more on the heart, slowing conduction and decreasing contractility. Hence, they are more commonly used as antiarrhythmics rather than as antihypertensives. Common side effects include ankle edema, facial flushing, dizziness, nausea, constipation, and fatigue. Serious adverse effects like cardiac depression and heart block occur mainly with verapamil or in patients with pre-existing conduction defects. Short-acting dihydropyridines can increase the risk of adverse cardiac events due to inadequate protective cover, which is why longer-acting preparations are preferred. In the next lecture we'll continue with sympatholytics, vasodilators, and combination therapy. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!